Thank you so much. Thank you so much, Ahin and GIJet for this coordination and inviting me for a presentation. So today we'll be talking about the role of openIMIS in advancing universal health coverage in Nepal. I will be giving a short intro on the health financing system of Nepal, basically of the health insurance program of Nepal, and I'm accompanied by engineer Suresh Singh Tinkari, who is working as the head of IT at the Health Insurance Board. So yeah, without further ado, let me start the presentation. Yeah, as agreed earlier, the learning objectives of our today's session is to understand the challenges and opportunities in health financing in Nepal, particularly in the context of universal health coverage, gain knowledge of how openIMIS and other digital solutions support the effective management of health insurance program, learn about Nepal's current use of openIMIS and its integration within existing health system, and identify the key benefits and potential barriers in adopting the openIMIS for broader implementation across Nepal. Let me introduce a bit about the health financing in Nepal. Nepal adopts a mixed health financing model. It combines public, private, and pool funding mechanisms. There are government funded, tax funded basic health services programs. There are insurance based, prepayment contribution based services. And there are private health services, which are basically through the out of pocket. So basic health services, they include a minimum package of care accessible to all, especially at the primary care level, which aligns with the equity goal. They are provided free of cost through public facilities, where the services beyond basic health services are paid in those facilities. The government pool the tax-based healthcare fund for conditional grants and subsidies. And the insurance-based model in Nepal, it involves prepayment contribution from household. There's subsidization from poor, and it creates a risk pool mechanism. And there is the major chunk, which is the out-of-pocket payment. That is a major chunk of the health financing in Nepal. And despite reforms, the out-of-pocket remains a major financing source, especially for the private and specialized services. And this exposes families to financial risks and is a key target for reduction under the universal health coverage schemes. And side by side, there are parallel other health financing mechanisms, which are voluntary private insurance, social security fund, employee provident fund, conditional cash transfers, impoverished citizens program fund, and etc. The figure in the right is it's from the our Nepal's latest national health account, which shows that the largest portion of the health expenditures, around 54%, still comes from household through the out of pocket. So, in the current health financing situation, the key challenge is how to reduce the fragmentation and build a coherent financing system that leaves no one behind. Nepal's policy commitment to UHC is strong, with strategies and plans setting clear directions. The National Health Sector Strategic Plan, National Health Financing Strategy and its implementation plan, National Health Insurance Strategic Roadmap, and the 16th National Development Plan from National Planning Commission. You can see that all these are very recent strategies and policies. All of them, they are focused on strategic intervention to expand fiscal space for health, strengthen social protection, improve the resource generation, and improve health financing, governance, accountability, and transparency. So like the UHC cube, which is on the right, I have a figure of the universal health coverage cube that explains the three dimensions on population coverage, services, service coverage, and financial protection. So Nepal's commitment to universal health coverage, it aligns with the definition of the UHC cube and aims to fill into the cube with expanding population coverage, services, and also the financial protection. The National Health Insurance Program is central to this. It is a contribution-based social health protection program of the government of Nepal, which is aimed to quality healthcare to its citizen without financial hardship. So in today's discussion, we'll be discussing more about the National Health Insurance Program. So let me go through a bit into history, the development milestone of the universal health coverage in Nepal, how it started. So in mid 90s and in mid 1970s, mid 70s, the first community-based health insurance was started in Nepal in Lalitpur district, a district in the Kathmandu Valley, which was started from primary healthcare center to a hospital in the district. Then in 1990s, with the wave of democracy, healthcare started to expand. And in 2003, more of the community-based insurance schemes were introduced in the country. There were 6 community-based health insurance in different districts of the country. And the similar wave continued to 2006, where for the first time, the free healthcare program was introduced, which introduced the removal of user fee and introduced 40 essential medicines in the basic health service package. And following that, in 2014, the new health policy and this national health insurance policy was endorsed, that for the first time brought the concept of national health insurance in the country. Following that, in 2015, the Ordinance for Formation of Social Health Security Development Committee was endorsed, and the Social Health Security Development Committee was formed, which formally started the health insurance program in Nepal. The National Health Sector Strategy 2015 to 20, it's also aligned with UHC and focuses on 4 strategic principles of UHC: equitable access to health services, quality health service, health system reform, and multi-sectoral approach. Then in 2016, the Social Health Security Development Committee, through the program, it rolled out the Social Health Security Program, which now is called Health Insurance, and earlier it was called Social Health Security Program. It was rolled out in 3 districts of Nepal as the pilot program, and it took the aim of expanding in all the districts, in all 77 districts of Nepal by 2020. In 2017, for the first time, the Health Insurance Act was passed, and that also issued the formation of the Health Insurance Board. And currently, if you see, the health insurance program is implemented in all the districts of country. So this is the operational framework of the Health Insurance Board that ensures governance and strategic oversight of the National Health Insurance Program. The Health Insurance Board is the purchaser. The role of the Health Insurance Board, it includes raising revenue, pooling funds for financial protection. So it receives the fund from contribution premiums, tax funding, and other external fundings, and organizing and purchasing from public and private providers. The Health Insurance Act and the health insurance regulations provide the legal provisions and strategies for implementing the National Health Insurance Program. So it's regulated by the government of Nepal. Alongside, for policy formulation, it looks at the Ministry of Health and Population. Ministry of Health and Population is also the service provider, while the Health Insurance Board, as already said, is the purchaser of the health services. And the Health Insurance Board collects the premiums from the insured population. So this is how the triangle of the purchaser, provider, and population works in the Health Insurance Board in Nepal. So there is an independent monitoring committee for claim verification that works parallelly at the Health Insurance Board. So Nepal's health insurance program, it has been structured to promote equity, efficiency, and access by incorporating several foundational features that are rooted in the financing principle. So it is based on a family-based contribution model. So this operates on a household enrollment model where families contribute to a set amount of annual premium. The health insurance program features subsidy to the poor and targeted group, which I'll come later in the next slide. The health insurance program is supported by the openIMIS integrated management information system that enables real-time data tracking, enrollment, claim processing, provider payments, and monitoring. So the provider, as said earlier, is managed by the Ministry of Health, while Health Insurance Board is the purchaser. So there is provider-purchaser split as well. The separation, it allows for performance-based contracting and better quality control through standardized packages and payment mechanisms. Another feature is the program ensures provider choice by empaneling both public and private facilities. This expands access to quality services and fosters healthy competition among the providers. Let's look a bit into the contribution and the benefit package under the health insurance program. The contribution amount for one household that includes 5 members Nepalese rupees 3,500, which is equivalent to $35, and it's an annual contribution amount to enroll into the health insurance program. The contribution amount is increases for increases to Nepalese rupees 700 for every additional family member. There is a subsidy, 100% subsidy for families belonging from ultra poor, patient living with HIV, multi-drug resistance TB, leprosy, patient with severe disability, and there's 50% subsidy for the female community health volunteers. And also there's 100% subsidy for elderly population above 70 years of age. There's a specialized benefit package under the Health Insurance Board, which includes all the promotive, preventive, and curative services, outpatient, inpatient, and emergency care. There's a benefit ceiling of Nepalese rupees 100,000. That's equivalent to $1,000 per year for a family up to 5 members. And for an extra added member, the benefit ceiling adds by 20,000 Nepali rupee, and that totals maximum to 200,000 Nepalese rupees. And there's an additional benefit ceiling of 100,000 Nepali rupee for every elderly population enrolled into the health insurance program. So this is the organizational structure of health insurance program. Currently, Nepal, with its federal government, operates 3 levels of government at federal level, provincial level, and local level. And likewise, the Health Insurance Board of Nepal, it has structure that spans over this 3 levels of government in the country. At federal level, there is the Health Insurance Board, central office composed of 9 board of members there. It's regulated by for the legislative aspect of the Health Insurance Board is regulated by the Ministry of Health and Population. And there's the Health Insurance Board central office is responsible to impanel the health facilities under the health insurance program. At the province level, in all 7 provinces, there are the provincial committee, coordination committee, which are regulated by the Ministry of Social Development, unlike the Ministry of Health in the federal level. And there are provincial and district hospitals who provide services at provincial level. And coming to the local level, there are district contact office in all the districts of country, and the enrollment assistant and enrollment officer are responsible to enroll the household to the health insurance program. The enrollment assistants, they reach door to door to enroll the household into the health insurance program. And at the local level, there are primary healthcare center, basic healthcare center, community and private hospitals, which act as the first service point of the to receive the health care services by the population who are enrolled. So the current status of health insurance program, the map here shows the current distribution. It shows both coverage and also some regional disparity to address. It spans from like 45% is in the province 1, which you can see on the right side. And the list one is 9% is in the Madhya province, is province 2, that's in the lower part on the right side. The figure on the left, it shows total insured. The number of total insurees currently at the Health Insurance Board are 9.2 million, and that's 26.5% of the total population of the country. And among them, the active insurees are 6.1 million, which includes insurees who are active, who have renewed their enrollment, paid their annual contribution. That includes 6.1 million people. And the total family, those are enrolled into the Health Insurance Board program are 2.9 million. That's 42.45% of the household of the country. And the service utilization rate is almost 49%. Yeah, it also depicts some challenges regarding moral hazard and people with riskier group more being attracted towards being enrolled into the health insurance program. The good thing is there are more female enrolled, 52% is, and there are 484 total health facilities participating as service provider through this program in the country. Yeah, besides progress, challenges remain. And some of the most pressing challenges currently are the high out of pocket expenditure, which ranges from above 50% of the current health expenditure. There's limited risk pooling. There are fragmented social health protection schemes running parallelly in the country. There are limited service capacity and quality gaps. There is insufficient inefficiencies in budget utilization and coordination gap in the country, and there is fragmented data system. So today we'll be discussing more about how these different challenges, how we are addressing these different challenges through applying the openIMIS in Nepal. And yeah, from now I would like to hand over to Suresh ji to continue with the presentation.
Hmm. Hello, everyone. Good evening. Thank you so much, Junu ma'am, for the next slide. Actually, I'm going to talk about the openIMIS. openIMIS is being used in the health insurance program. How it gives the digital solution for the health insurance in Nepal. So, why we use the digital solution like openIMIS is really it contribute to the efficiency management of the insurance program or in the equity level of the management that the openIMIS the being used in the health insurance program in Nepal. So by the evidence and the global practice, which shows that the digital license actually reduces the delays of the working process, and it also increase the efficiency and enhance the accountability and transparency of the system. And it also helps to enable the smoother interaction between the complex data intesting system in health and beyond the health sector as well, where it suppose we use the number of data from the openIMIS, and so it helps to support the data driven decision making and the strategy policy planning as well. And also it facilitates outreach to remote areas and the vulnerable population as well, where the openIMIS actually we are using in the health insurance program in Nepal. For next slide, Junu ma'am, can you please? Yeah. So also we have a success story in the progress where the openIMIS really do for HIB. The open source like openIMIS. Actually, the insurance management information system is a core digital platform for Nepal where it manage the national health insurance scheme. Actually, the openIMIS was developed in Nepal for the national health insurance scheme since 2016. And initially, the openIMIS was adopted from the Tanzania and Cameroon implementation as well, where now we have the rapid expansion of the health insurance program currently in all districts in Nepal. And here we have mentioned the key implementation and the future which we use in Nepal. And yeah, the ability of the Android-based application for the enrollment has meant for that enrollment assistant can go to the door to door to bring the household into the system or the scheme in the health insurance. And we have also the web-based claim entry. The claims entry and other adjustications model significantly this reduces the paper-based transaction and actually reduces the paperwork of the health facility as well. And this has enabled the health insurance board to achieve the current rapid rate of the expansion as well. Next slide. Here we have the claim processing working flow. This working flow just shows how the health facility verify the membership and the policy details through the openIMIS, and how the claim is submitted and adjudicated using the openIMIS. And finally, the reimbursement is done when the claim is verified based on the relevant documents submitted through the system. Actually, by use actually the claim is verified in the HIV center team came from the different hospital as well with relevant document as well, and that's the submission part of the Yeah, and the patient visit to the hospital for taking the service, and in the case of the in the hospital where they are using the openIMIS or their own software to facilitate and to verification of the policy details of the patient as well. Yeah, next slide. Yeah, openIMIS experiences in Nepal. The use of openIMIS actually it helps to enable the quick implementation of the management information system for the health insurance, and we also have the continuous support of the openIMIS committee of practice. Which has to enable the learning and sharing information between the different country contexts. Which has to align the regular update of the system for Nepal, and right now we are using the we are using the legacy software of openIMIS, but we are going to plan the regular availability of the new version of the software with new feature as well. And in the availability of the country level capacity, the human resources which manage and maintain the software as required as a requirement of the users. And in Nepal, we also have the local vendor which actually, the worked in the global platform as well, related to the openIMIS as well. Next, this is the part of the integration and interoperability. As you've seen on the picture, in the middle part, the openIMIS, which is a core software to manage all the function of the health insurance program, and we have added the Fire API, which has enabled the health facility to submit the claim easily. And we have also developed the mediator, which acts as a bridge between the different payment gateways and other government service as well, government services and openIMIS. Next, the other initiation from HIB. Right now, we have the HIB profile application. It keeps the information of the insuree, where as you seen in the picture, openIMIS is a core software to manage all the function of the health insurance program, but actually previously the openIMIS didn't have any functionality where an insurer can see his and her details about the insurance policy and the claims and the service provider and the service covered by the health insurance. But HIB developed this mobile uh, application where it helps to for the profile application. Insurer can show by using the virtual card during the verification of the health facility as well, and stay informed and take their decision as well. As today, more than 50k plus thousand plus injury has already downloaded this application, and we are continuously upgrading this application to add the new feature and new functionality as well. Next slide. Okay. This is also another initiations by HIB. That is the online renewal is another functionality which was launched the last 2 years before. The insurer can renew their insurance policy online using the different mobile wallets and the payment gateways. And as of now, we have more than 11k plus families have actually renewed their policy by online. Next, this is the new initiation by HIB, but right now we are not going to launch the online enrollment, but it is in the testing phase right now. The online enrollment that where the citizen can register online in the health insurance program. Actually, the one of the priority of the online enrollment, which is compulsory for the when insurer that they already got the national ID card for the verification, so that they can enroll online enrollment by using the web based or the mobile application. But still, we are in the testing phase right now, so we can't use. We are not going to. We are planning to launch the online enrollment as well to facilitate so for the payment through the mobile wallets as well the web based system. Yeah. Okay, I think this slide I would like to request to the Junu ma'am to be continued for this slide.
Yeah,
Thank
thank
you.
you so much, Suresh, for explaining about how openIMIS is in application and the Health Insurance Board, Health Insurance Program of Nepal, and how that how your department is working in updating and using it more to address the more challenges of the Health Insurance Board of Nepal. So now I would like to focus you a bit about how openIMIS has been addressing the challenges of the health financing and how it is still able to address challenges looking ahead in the future. So, from low population coverage, using the mobile applications, the easy verification system, easy payment mechanisms, it enables people to enroll easily. So, it helps in a certain extent to deal the challenge of low population coverage. It removes that hassle regarding payments and other paperworks. It also deals with the challenge of high out of pocket expenditure because there's efficient claim processing and reimbursement. This supports cashless system for beneficiaries and also promotes financial risk protection. As Suresh already mentioned, people they can download their own information that they from the application and they know about um, their benefit packages, their benefit ceiling from the mobile application. It also can have the capacity to deal with the fragmented scheme of the country. The modular design of the openIMIS it allows adaptation to various other schemes in the country, like the Social Security Fund. And yeah, as said earlier, it also deals with the inefficiencies and the administrative paperworks. And beyond efficiency, it also enhances monitoring, fraud detection, data driven policy making, and it also makes the digital tracking and analytics in convenient way. So looking ahead, we aim to expand the services, harmonize the scheme, and implement strategic purchasing and integrate the AI for smarter claim management. So international collaboration has played a key role in this. We are thankful to GIJ, ADB, and World Bank for supporting in policy, research, and capacity building efforts. So here we come to the close of our presentation, and we both are happy to take the questions that you have.
Yeah, thank you so much, Miss Juno and Engineer Suresh for your wonderful presentation. We have learned a lot, so now is the time for our open forum. So I think we have started to receive some questions from our Q&A box and also through our message. So for the first question, we have a question from Dr. Budi Setiawan from UNICEF Nepal. Dr. Budi says, as per definition, the health insurance should not purchase services from a primary level as they should have been covered by the basic health service benefit package, which is tax based, right? Dr. Budi, if you want to open also your mic, feel free to open your mic so you can also further expound on your question if you wish.
No, thank you very much for the presentation. Just to clarify my understanding to Junoji, because I think when you explain about the level of service offered by the health insurance program, I think there is still a bit of unclarity in terms of the different level of care, right? Because I think there is this, I mean, it's been quite a dispute between, you know, what HIP covered and what BHS covered. Even we have something that BHS covered at the secondary level as well. On the other hand, we have also something that the health insurance cover at the lower level. So because I think it will also, you know, it has a pragmatic implication in terms of the how the open IMIS, you know, should be scaled. Because now if we limit ourselves only to those at the secondary level where the target of the health insurance program should be, then it will also give an efficiency from our side. Thanks.
Thank you so much, Dr. Buddhi, for your question. Yeah, this has been something that the Health Insurance Board has been working on since a few years already now. The duplication of the basic health services, service provision, either from the government or from the Health Insurance Board. So, as per the policy, as per the Constitution of Nepal, the basic health services they should be provided free of cost and should not be from the Health Insurance Board's benefit package or from this program. So we have realized that duplication at Health Insurance Board, and currently we are working yet to remove that duplication and provide the basic health services from the public facilities free of cost, either it's like primary, secondary, or at tertiary levels. Yeah, that's something that we are still working on, Dr. Buddhi. If I if I could
Yeah, so
briefly answer your
so the
question.
question to you and also to Suresh then, what is the plan for the scale of IMS now? Because I think we have, yes, you said that it's now covering the whole district, the 77 districts, but I think it's also not visible in terms of efficiency, but also future planning if you try to also cover the whole primary sites, right, for HIB to be able to scale this. Thanks.
Yeah, that's where the openIMIS help us in reducing and managing the duplication. Engineer Suresh, would you like to add something, like how are we dealing on that?
Okay, thank you for your query. Actually, the openIMIS, we use the openIMIS where we have a fire standard API HL7. So that we we don't have the completely the EMR system to connect with the openIMIS, but partially we give the fire API to the health facility so that by using their EMR or their own billing software, they provide the service to the patient, and after that the real time API which we had provided to the hospital so that they can to submit the claim electronically by using their own software. But this is the fragmented, the EMR interoperability between the EMR and the openIMIS. But in future, if we are also planning to, operate the EMR and openIMIS interoperability for the complete, the system there, so that the doctor can prescribe by using their own laptop or the electronic device, so that the prescription as well as the discharge summary which will come in the openIMIS, using their own software. Right now, only the claim submission can be submitted by the different level of the hospital in more than I think we have 485 the hospital has facility right now, so that more than 350 above hospital we can provide the API file API to them, so that it can easily provide the service to the patient. Yeah.
To add a bit more clarity on that, Dr. Buddhi's question, the basic health services are not eligible to be claimed through the health insurance claim through the health insurance claim, and if they are being claimed under the health insurance scheme in Nepal, they are looked by the claim reimbursement committee, and they are not taken forward because they should be provided by the government free of cost and not included into the health insurance program. So, but still, there are some challenges going on to completely check on that. But the benefit package that's currently running under the Health Insurance Board of Nepal, it excludes that basic health services.
No, I think the question is clear, but I think the issue is that you have also secondary level services covered by the health insurance happening at the primary level. Now we have, right, the pressures of some municipality hospital. They want to open their own hemodialysis, going to the minister, etc. So that will actually have that implication. I think, secondly, also the question that I would like to ask, then what is your vision also in terms of trying to have actually unique identifier and master patient index, because I think your plan with the ID card is great, but I think with the situation of Nepal right now, it will actually have more exclusion errors, because then you have the poor and the poorest people will be excluded because ID is something that is not also universal for Nepal. Thanks.
Yes, of course. Sureshi, would you like to add a bit about the national ID card and then so how we are working on creating the unique ID number for the injuries?
Okay, sure. Yes, so what Dr. Bhuti just said about the national ID card as well as the health ID card. Actually, the Ministry of Health uh, are going to plan to develop the national, the health ID for the individual uh, patient as well as the foreigner members as well. But in the case of the HIB, we are going to plan the national ID card as a unique ID identification number, where we found the personal details, so that it will be easy for the HIB or the we use in the open IMIS field, so that the unique ID, because right now if some of the patient in different the district, they have they had got the two or three number of card they are using when they are going to this take the service from the hospital. So this is the duplication part by of the HIB right now. But in future, if we are going to take the national ID uh, by using as a national ID, as a health insurance card as well. So it will be easy for us for the unique identification for the HIB, so that this level of the duplication will be reduced by using the national ID card when we are going to interoperability with the national ID card. But still, we are going to plan to the national ID office to contact between health insurance board and to the national ID card. So it will be easy for us to provide the service as well.
Thank you for that discussion, Dr. Budi, Miss Juno, Engineer Suresh. We have another question from the chat box from Dr. Julius Fibrino from the Philippines. So he's asking, can you provide a quick background of EMR use in Nepal, its historical availability, coverage, and integration with openIMIS?
Just now, I just explained about the EMRs, where in the Nepal, the different hospital, like government as well as the private hospital. Actually, the more of the hospital actually use the EMR system, their own software, but more of the hospital use only the billing software right now. So for the interoperability or integration of the openIMIS to the between the EMR or the other billing software as well. Uh, so we just only provide the partial, the provide the API for the submission of the claim, so that it will easily we get the number of claim by using their own software like EMR as well as the billing software. But this is not a complete EMR where the hospital or the doctor who uses the EMR software for a prescription as well. But in some department like gynecologist department, like some orthologist department, in some of the health facility who completely use the EMR, so that they can provide the service to the patient, and they can submit electronically by using the interoperability between the openIMIS and EMR.
Thank you. Um, do we have more questions? So for our participants, please feel free to raise your hand. We have a question from Mr. Anis Fuad from Indonesia. Pa Anis, over to you.
Thank you, Christine. Thank you very much for this presentation from Nepal. We are happy to hear this presentation, because currently in our team in Gajah Mada University, we are trying to adopt and learn openIMIS in our laboratory setting. And then we would like also to understand the Indonesian national health insurance system in the real life, and then compare with the openIMIS data flow and system. I have three questions, just a quick one. The first one is whether in the primary care do Nepal implement the capitation system or not. The second question related to the claim from the health facilities, whether you also implement the prospective payment like diagnostic related group or not. And the third one related to the module uh, for the fraud detection, in which you also implement the AI system. My question is, I think it is also dependent on whether you implement the diagnostic related group or not. Um, would you please elaborate more about the fraud detection system? What kind of fraud that has been detected, or what kind of the mechanisms to that openIMIS identify the fraud from the claim of health facilities? Thank you.
Thank you, Anil. Anis, yeah, I would like to take the first two questions regarding your payment mechanism at the primary level, and if we are using the DRG related payment mechanism. So unfortunately, we are still not using the capitation mechanism at the primary level. We still use a fee for service payment mechanism. Our benefit package is designed in a way that the reimbursement or the payment can be done for the services, and we also have case-based payment mechanism where we have in the benefit package identified cases that can be paid for the inpatient services at the secondary and tertiary levels, but at the primary level it's still fee for service payment mechanism that we are using. And regarding your third question on fraud detection, there are a lot of fake claims that that we have detected at the health insurance board. I would look to Suresh to elaborate a bit more about how the openIMIS has been useful in detecting those.
Okay, thank you. I think the SIB's plan is actually the plan to implement the AI on the openIMIS in future as well for the claim for fraud detection as well. So we want one level of the the openIMIS have already had the one level to identify the features that actually the number of claims came from the hospital, as it is a real or not by the using the relevant document as well, which is provided by the hospital. But actually the medical officer who will going to review the claims in that part, it will be very difficult to identify the actual claim came from the hospital is real, whether the patient will the provided service by the hospital or not. So in future we are going to plan the AI implementation in the openIMIS, so that one level of the the verification where the number of claim going to review for the medical officer. Before that, the AI just pre-check the number of claim to, so that it will be easy for us to provide the the reimbursement to the hospital as well.
Thank you. May I have one more related to the mobile apps? Actually, we have already installed the openIMIS in our server. We do not have more detailed information whether this openIMIS could also be used for the mobile app. My question is whether we need to install additional module for the mobile app of openIMIS. Over.
If you talk about the mobile application, right? So we have the different Android application where the insurance also use their information, whether when they had to go to the hospital and they take the service, and whether they check their own services, so the mobile application is customized by for Nepal. We also can share the details to your team if you need it. We actually have the SIP profile as well for the insurance, where they check their own services, whether they how how the benefit package as well they can take to the service from the hospital, so that it will be easy to identify that my service is this one, and so that the check-in balance by the hospital and the patient between us is actually the correct or not, so that it helps to us. So if you need it, then we can share the details of that to your team.
Okay, thank you very
Thank you. I think Dr. Basanta Joshi from Tribhuvan University in Nepal also raised his hand earlier. Over to you, Prof. Basanta.
Thank you, Christian. Thank you, Junuji and Sureshji, for a nice presentation. So, in from your slide, I saw that almost one third of Nepalese populations are registered in health insurance board, so about 9.2 million. So, and just a few moments ago, Sureshji explained that we are processing the claims using medical professionals. So, I want to ask about the statistics, like how many claims are being registered daily and how many claims are being processed daily. And because I have tried to approach HIB before, we have written some letters to HIB. Maybe Suresh I had told some students to meet Suresh and the personnel from HIB maybe long time ago. So we tried to get the data, and somehow we want to assist in collaboration with GIZ, HIB, or SF in implementation of openIMIS, or in automatic classification of claims. So I have two questions. One is about the statistics. Another is Junuji mentioned in last slide that like HIB has been collaborating with international organizations. So what are your plans in collaborating with academic institution for research, and like some kind of student who may be able to assist HIB in doing some projects. So that is my question. Thank you.
Yeah, thank you, Basanta sir. Suresh, you would like to take the first question, and I'll go for the second one.
Okay, thank you for your queries. Let's just talk about the number of claims where we got the number of claims per day. We got the 50K number of claims from the different hospital as well. So in per day, we only in we the medical officer, whether in the central level team, the 25 staff as well we have here. So they can review the manually the number of claims, and they also use the random sampling in the system, so that it it helps to reimbursement the number of claims. So you just talk about the data sharing. The data for the data sharing. About the data sharing, we have the policy terms and some guidelines which has recently been endorsed. This is linked to how data can be used for research, right? So definitely linking with HIB for the academy as well, the research for the further thesis as well. So we have some guidelines or some rule and regulation procedure. To provide to share the data by using that guidelines. So it will be till now it will be easy for us to provide or sharing the use data to us.
Yeah, thank you, Suresh. And to your question on linking academia research with the Health Insurance Board, so there has been always the discussion of having a research department for its continued improvement. And I'm sure that Health Insurance Board, we are open to connect with, to work, collaborate with the academic institutions for research. And as Sureshji mentioned, that we have recently endorsed the data sharing policy, so which allows the students or the researchers to access the data from the Health Insurance Board. So I think we can keep in touch after the session offline as well regarding how we can proceed on that.
All right. Thank you to our participants and, of course, our speakers, Ms. Juno and Engineer Suresh, for our discussion for tonight. It has been a lively discussion. I think we are now reaching the top of the hour. So before we wrap up, we wanted to invite everyone to turn on their cameras for a quick picture taking with our speakers. So let me fix it first, and then I will, um, yeah. So everyone who wants to join, please turn on your cameras. So 1, 2, 3, smile. Wait, let me fix quickly. Hold on a bit. All right. Um. Okay. One more. 1, 2, 3, smile. So, okay, thank you everyone for joining in tonight's webinar. We'll have more webinars this month and in the coming months. So, thank you for your time, everyone, and to our speakers. Have a great night. Bye.